All right, Sarah, this is the off script for Burnout. 3, 2, 1. All right, loyal listeners, for those of you that followed us over to Patreon, welcome. We're always glad to have you. This is the bonus content for the episode that we just recorded where John took us through a history of burnout. And John, I'm impressed. I stayed awake through the whole thing.
Well, history is beautiful.
I do love history, so I can appreciate it. You know, I hope that listeners can appreciate, because this is, I think, a drier topic, and I don't mean that to be an insult to you. But I think it's really important to kind of set the stage. We talk about burnout so much professionally, and everybody talks about it just with the assumption that we're all using the same definitions, that we all know what it is, we all know what the causes are. So I really am excited. I applaud you. I appreciate that you're taking the time to break this down into a detailed multi-episode series of what exactly this is, because if you really, it's, you know, we're all in medicine. If you understand the disease, you're going to better understand how to treat it or find a solution.
Oh, I think that just like in medicine and any sort of treatment plan, overutilization diminishes the potential outcomes. We've overutilized the word clinical burnout or burnout, where because people hear it, they drown out. They're like, oh, yeah, that just means we're sad and tired.
Yeah,
Like,
I think that's
no,
right.
It's not. That's not the case. There are things that companies can do, and there are things that we can do to help with this. So, before we get started on our personal stories, I think this is kind of hilarious. Not funny, but it's one of those. If you don't think it's funny, you know, if you don't laugh at it, you're going to kind of cry about it. Just like Marines or just like any service member in our armed forces, we make friends and brothers in foxholes, right? But this is a statement off of one of the articles that I cited on our episode by Dr. Drummond and Cordette McCall. Again, I'll post it on this one as well, the link to the article. But I quoted them as saying, quote, burnout individuals just don't care, end quote. Now, I want to expand that just a little bit, because one of the symptoms of burnout that we're going to talk about on the normal episode, is this how I'm identifying it now, Mike?
Maybe.
The normal episode? And on our white coat episode of clinical burnout, episode number 1, I did not talk about symptoms, but here, let's talk about one symptom here. Depersonalization, okay? Depersonalization is one of the symptoms, and not really identifying your patients as human beings anymore.
That's interesting.
It's not that you're viewing them as animals. It's just they are an object to be fixed, like a carpenter sees a hammer, nail, and piece of wood.
I think that's so fascinating. And you know what? It makes sense, though, because I think we talked about in the main episode, one of the biggest draws to medicine is the connection, the fact that you can help people, that you can make a difference in their lives. And if you lose that sense of purpose, if the patients no longer are, you know, individuals in need where you get to make a positive impact on their life, but rather just become cogs in a wheel or just yet another encounter, that can make it really tough to find that meaning and purpose. So it makes complete sense.
Let's get raw for a second then. I'm going to be very honest here. And if I feel like something I say might be critical to my work, I'm going to ask Sarah just to take it out. But there are a couple of things I want to talk about with the pandemic. This is pharmacist specific at this point. But currently right now, reflecting on the past months to a couple years, I would say that it's been more difficult than ever to view patients as human beings. And I'll tell you why. This is a little bit of a sobering fact, but we never got a break as pharmacists. We never shut down. The only time we ever shut down is if you got COVID. And if your whole department got COVID, you've seen pharmacies, they're extremely close together. And I don't work with a pharmacy that is small by any means. We have sometimes up to 20 people, 25 people at a time working in a small area. So you see people buzzing around back there. That work still needs to get done. People were sicker than ever. medication, the prescribing patterns went up. Okay. We had less labor, more work than ever. Then the government gives us the vaccine to give to the population, which I think is wonderful. I think we're the easiest people to get it from. Now, we were not, I want to say we, I'm going to say we as a pharmacist group were not very excited about it. I like immunizing. I was ready for the challenge. There were people who were having panic attacks, Mike. I mean, right when they heard the news of what was happening, they snapped. I don't say that in jest or humor. They broke down, cried, had to go home, had to have some FMLA. It was just bad because we did not stop. We sped up. So when you come to the pharmacy, and we've been in this position for years now, and you start yelling at us about why we're holding a controlled substance to the date that New York State makes us to, or when you start yelling at my technicians about how you're going to die without this medication, but it's an eye drop. When you start coming and complaining about the cost of a prescription that your insurance charged you off of your formulary, and then you blame it on us for not taking care of the patient and not caring if you're going to die or not, I can't tell you the visceral feelings that we get from that. How we feel that you are ungrateful, how we feel like you don't understand what we've gone through this past year, because what might be a minor inconvenience for you are nights awake, maybe crying with your spouse because you can't take it anymore, right? Insomnia, thinking all I know is I've got to go back to the same job tomorrow and sweat my balls off, not go to the bathroom.
We're off script. You can do it.
I got to go take a crap at work, Mike. Guess what happens? They don't mean to do this, but your colleagues look at you and be like, where the hell do you think you're going?
Yeah, and once again, Sarah can cut it out, but even just in our conversations that we've had, it blows my mind because you and I often talk during the day and we may chat, in between patients for me. Mm-hmm. And I'm busy at work. I see a lot of patients, but I also, as a provider, have the opportunity to just let my patient wait for 10 minutes in the waiting room if I want to have a phone call with you.
When do I call you?
I was going to say, I can't even fathom the fact that if you were at work, you've called me before and you're like, I'm hiding in a closet. No one can know I'm on the phone. And that just blows my mind. Mm-hmm. As a doctorally trained professional, that mm-hmm. you're not able to find time in your day. If maybe there's a little bit of a downtime, or maybe you just don't have that, but to just take a quick 5-minute phone call without that being, viewed punitively by your employer, it's crazy. And mm-hmm. once again, I'm not necessarily knocking your employer, because it may just be that the clinic is so busy that even 5 minutes away is unattainable. So it may be an issue with just demand, but it always blows my mind that we have to only talk on your lunch break, or if you call me at work, or if we try and talk at work, it has to be secretive.
Yeah. It's, I don't want to say, I know that employers can do better. We know this, but so do the employers. The employers are seeing that people are leaving. There are meetings happening all the time saying, okay, how can we retain these people, right? These are questions that corporate entities are asking. Why are people leaving? So they want to know too. They might not be able to do it at this point. So we have the want and the need, but they might not be able to fulfill at this time, right? Mm-hmm. We're not getting reimbursed what we should be getting reimbursed to hire more pharmacists. So I'm not blaming my employer. Don't hear me wrong on this. I'm saying that is where work is right now. That is why the nurses left in droves. That's why they're on strike right now. The hospital system, could they do something? That's a whole nother thing about hospital systems. Healthcare systems, Mike, you and I could talk off script about that. But it's not that we don't know that there's something that needs to be done. It's that everybody does know and might not be able to do it or don't know how to get there yet. So I am frustrated as a pharmacist. I am tired. I'm not seeing people in the same light as I used to. And if you know me personally, if you're a listener, you know who I am, you probably are thinking to yourself, John, that's bullcrap. Like, I know you love people. You spend as much time as you can with these people. Yes, I do. My colleagues probably hate me for it, but I would like to do that more. I want more FaceTime with you guys. I want to teach you about your diabetes. I know that pharmacists are sending you home with your first time Ozempic, and your doctor said, I'm sending you an Ozempic, but you've only ever taken metformin your whole life. Good luck with shots. It's like, we understand that that's happening. Right. I want to spend that time. So I'm gonna digress a bit because it is an emotional thing for me. I did not go into this to push medications in more units per minute. That's not what I went into this.
Yeah, I think so. I'll, also be transparent.
Okay.
Yeah, because I think it's good. I like on the Oscript talking about, our own personal experiences. Although I think it would have been funny if you have this incredible, raw moment where you're sharing your hopes, weaknesses, and dreams. Then I'm like, yeah, I'm good. But
ditto.
Yeah. So on my end, I'm weird because I consider myself blessed. I don't think I have ever had clinical burnout. I don't think I've ever had a day of burnout. Every single day that I've gone to work, I've enjoyed what I do in terms of patient care. Now, does that mean that I don't have stressful days? No, of course not. I have days that are stressful. Even in those stressful days, I don't look at them and say, I don't know if I can keep doing this, or this doesn't bring me joy. I love caring for patients, and maybe that's a problem because I think, my interests have continued to expand, and I really like the administrative side of healthcare. I like the business of medicine. I don't want to leave clinical. So I'm stuck in this crossroads where I'm wanting to do everything at once. Mm-hmm. But just because I don't have burnout in the sense of, oh my gosh, I need to leave clinical medicine, doesn't mean that I haven't had days where that frustration of I can't see this many patients in a day, mm-hmm. or I'm not able to give the care that I want to give because of the external pressures. Mm-hmm. And similarly to what you were describing, there's stuff that's going on in healthcare, and certainly employers may be playing a role in that. But in my case, a lot of it was just demand of patients. When COVID hit, mental health didn't get better, it got worse. Mm-hmm. So the patients that I was seeing every 6 months because they were stable, all of a sudden became unstable. So mm-hmm. the demand for our services went up exponentially because the mental health needs went up. And we were still working with the same staffing model that we've always had, and yet we were expected to do so much more. And, how can you say no when you've got patients calling saying, I got furloughed or laid off from my job and I'm having panic, I'm going to lose my insurance, what do I do? Mm-hmm. So the past 3 years, there were aspects of it that were very tough, but never through that did I feel like this profession isn't for me. I don't know if mm-hmm. I can continue to be clinical. Now, let me expand on that a little bit, though, because I really love my role at my job. I have kind of a foot in both camps. I run a department, so I get to do a little bit of the admin side of medicine while also still being a clinician. Mm-hmm. And we talked about it a bit on the main episode. It is so hard, because the reimbursements in medicine are unlike any other part of the economy. If you have inflation hitting you, if salaries are going up, if you worked at McDonald's, mm-hmm. And you own the restaurant, in theory, you can raise your prices. Mm-hmm. But in healthcare, we're stuck. Insurances have negotiated contracts. Medicare, Medicaid have specific reimbursement rates. So even if the cost of labor goes up, even if inflation, so the cost of supplies is going up, our revenue is not going to change. So we always are in this constant battle to do more with less. And the past 3 years, the demand for services has gone up because of COVID, and yet reimbursements haven't. So you're in this constant struggle to figure out how you can just squeeze a little bit more water out of that rock. And it's tough. But some of the things that we've done internally in our department, because we have in our department, in psychiatry, we have some of the lowest turnover rates out of the entire practice, out of our company. And I think some of the things that we've done that have really made a big difference is we've tried to give employees and providers as much autonomy as they can. Yeah. Because I think one of the biggest things that you can do to combat burnout is have everyone feel that they're respected, have everyone feel that their contributions are meaningful, but mm-hmm. then also treat them like adults. Yep. So for example, we have nurses that, used to work in the office every day of the week. All of our nurses now are on hybrid where they get to work at least a couple days a week from home, and they'll mm-hmm. do phone triage, they'll do refills, they'll do all their tasks. But because of COVID, we now have the technology to do remote work. that's a huge benefit for quality of life. It's a huge perk for them to only come to the office twice a week. For providers, we've always had, metrics for our providers. We have to see X amount of patients and these revenue, measures that the providers need to hit to make sure that the department is healthy. But what our manager and what our company has done is several years ago, this was before COVID, she started shifting to basically say, this is the number of patients that you need to see. You can schedule them however you want. Mm-hmm. So there's no, this is when you're going to work. The providers make their own schedule. And, if they want to see patients at 9 p.m., we're not going to staff that. We're not going to provide people to staff that. But we have a physician that sees patients at night. And he does it without an MA. The patients, psychiatry allows you to do that, but, he just doesn't work with support staff. We have other providers that work, in different hours, and they just do telehealth. So then they can work from home, but they can set their own hours. They can set their schedule up in a way that's conducive to them. And I think that it gives them some agency, which can help combat burnout too. It's not always pay. It's not always workload. I think it's meaning, it's purpose. It's feeling like you're contributing, feeling like you're respected.
So to that point, and this is a little teaser for our next episode, but where they've identified that clinical burnout occurs, they imagine it like a seesaw. And on one part of the seesaw, you have work and stress, right? And the other side, you have respect and support. So as long as you have that stress, like everybody's going to experience workplace stress, but if you don't have any support from your, corporate, uppers, colleagues, anything like that, if that's gone, if the bottom falls out and it's just the stress, that's where clinical burnout occurs. So I think that's where the differences between us is that you're at a smaller organization. You have clinicians and colleagues that have a lot of say in where the practice goes, but you're also your organization admins recognize and work with you and listen, right? Now, in pharmacy especially, the voice of the pharmacist isn't as strong. We make a lot of money for them, but we don't have a lot of leverage, because how many kids are out there right now getting out of school with no jobs? They're taking it.
Is that because they're highly replaceable?
We're very replaceable right now. I mean, we have tons of more experience and we can function better, but they'll take a 25% less in workflow efficiencies to pay somebody 75% of the cost for you. So we are expendable people. That's what we feel like. We feel like, well, if I don't go in, if I don't do this or that, they're just going to fire me and replace me like that next day. So that is a realization. I want to stress this. If anybody is listening from my organization, I want to stress the point that this is a pharmacy-wide issue that we need to resolve. This isn't necessarily a single organizational problem. So I want to make one more point to adding the issues onto the pharmacist. Now, talk about you have autonomy, right? That you have the ability to see patients and bill patients as you please. Do you know what PBMs are doing with pharmacists right now? Are you aware?
I'm sure it's evil.
Oh, it's evil. Now, I hope that I get somebody from a PBM on this podcast at some point.
We should do that. That'd be fun.
Because I would like to discuss this, because maybe there are misconceptions that I don't understand, but I can tell you with the information that I know, and I have a pretty high level understanding of how these reimbursements go, because I was educating pharmacists and teaching them on MTM platforms. But are you aware that under CMS, Medicare Part D, hypertension, diabetes are the largest of it, but also hypercholesterolemia, hyperlipidemia. They are measuring these folks for outcomes-based star programs, or rather your star outcomes. Well, we have star ratings as pharmacists as well. But guess what the star ratings are based on? They are based on how often patients are actually filling their medications. So if they are not filling at 90+%, or rather this, if you fall into the second tier for pharmacists, for pharmacy patients rather, where your pharmacy has pretty good adherence to their medications as patient load, but you might have a Walgreens that is, maybe 92%. Well, if you don't fall into that percentage range, you have put an extra dollar in as an organization. If you don't do well, they keep that dollar. If you do pretty good, they give you that dollar back. If you are doing pretty bad, if you're doing very, very well, you get everybody else's dollar. Off of patient adherence, do I control how Mrs. Jones remembers her lisinopril at night? Am I responsible for that? The PBM says so. We're taking your money if your patients aren't taking their meds.
I think that's the hard thing with value-based care is great in the sense that it's more outcomes focused. And I think that's good because the fee-for-service model, I think, incentivizes low quality care. That's probably, I'd love to do, as we're talking about this burnout series, I'd love to do an entire episode on low quality healthcare because there's estimates that upwards of 20% of healthcare expenditures are low value, low quality care. And by that, we mean unnecessary testing, labs that are not needed, follow-up visits that could have been done over the phone. But
you have to do it, right? If the insurance company says, well, if to do this, you have to do that, well, we just wasted money.
So maybe a low-value care episode would be a really good one because I have a good book, then we could whip that out real fast. But
okay, let's back off of that. Yeah. That's why there's burnout in my life. Yeah,
I agree. Yeah. So it's interesting though because I think value care is a good thing. Moving to that model is a good thing, but the health system is not evolving quick enough to adopt that. You end up with policies and procedures that are still based on fee for service. You do a service, you get a reimbursement. And I think so much burnout is caused by this incongruence between how we want to move to a payment model versus how we are used to doing it, where we're asking people to do more and more and more, but then the reimbursement is still just very small. We're reimbursing them for the clinical encounter, but then not reimbursing them for the 20 minutes of care coordination, document review, where in theory, in a value-based system, we would get a global payment that covers that all. But my hope is that in the end result will be better once we fully transition. And maybe this burnout epidemic is just growing pains as we move away from a fee-for-service system.
I get it. Like PBMs, they don't want to give you more money
PBMs are evil. We can just agree with that.
I'm just saying they're not going to give you more money so you can hire a pharmacist to do, I don't know, some bull crap job up at a corporate. Like they want outcomes, right? So if they were giving you extra money for reimbursement, it's just funny to me because they're the ones giving us poor reimbursements, right? But they're also demanding that we have better outcomes. So because that high load of stress is on us and we can't do much about it, not enough lobbying and not enough support. I mean, that's the big thing. If we have the high stress but no support, that's why we have the great, I want to say exodus, but that's why people are exiting healthcare.
I think I read an article recently. I think it was 55% of physicians identified as burned out, and something like 30 or 40% of nurses and providers were thinking about leaving medicine in the next year.
46% of folks who left has already left said it was directly because of burnout.
Wow. Yeah. So it's only going to get worse. I mean, if 30% of people leave, then that's that many less people to be there and actually take on the load.
I think teachers are next, man.
Yeah. Well, so that's a whole, I mean, the health economic,
I'm just saying,
the economic side, disruption is good. Disruption is painful. It's hard when disruption may be affecting our individual careers, but I'm a big believer that education and healthcare are the two areas of our economy that they're chewing up so much money and they are so inefficient and so ripe for disruption. So I don't know if burnout is a sign that change is coming, but I hope, that this is maybe the death gas, the agonal gasps of a system that's just not working where major reforms are coming.
I agree. And I really hope that it didn't come off as complaining. It's a frustration. Because I recognize that there are changes being made, and we pharmacists ourselves, that's what you and I are doing, Mike, is we're here to help people see that you can become healthier and maybe not even leave your current position. So don't see this as complaining, everybody. See this as outward frustration that had been bottled up for for 3 years, and we just know that there needs to be change.
I think that's a great point.
Please understand that.
The goal of White Coats is not to get everybody to quit clinical work, but rather to find meaning and purpose, whatever that looks like. Maybe that is, making changes in how you do things at your current job. Yeah. Maybe it's finding another clinical job that's more fitting to what your interests or passion are, or maybe it is leaving clinical medicine. But the goal of White Coats is to help listeners find that fulfillment. Yeah. There's not going to be one path for everybody.
Wonderful.
Hey, I think that's a good spot.
I think this is great. If anybody wants to talk about your experiences, I think it'd be wonderful if you reach out, and we can even include it, because we're going to be talking about clinical burnout for a while. And if you want your story read, we'll read it off. If you want it to be anonymous, we'll keep it anonymous. But I think it's important to have raw, real reactions to what's happening in our lives as clinicians.
Awesome. One other thing for our patrons is, I don't know if you noticed, but we recently posted a couple job listings on the patron page. We're always trying to find opportunities to build value for you guys. You are so loyal. And as you continue to support us, we want to make sure that we're in return showing you our appreciation. So let us know, if there's something specific that you'd like to see as part of your patron membership, shoot us a message. We're always open to making changes to how the patron program is working. What I'm going to do and what John's going to do, though, is we get to have so many amazing conversations and network with people through this job, through White Coats.
That's right.
So if we're able to identify, great opportunities for non-clinical jobs, we're going to post them on there. The last two that we posted were both jobs that were specifically looking for clinicians of any profession that did not require prior experience either in health tech or as an MSL. So those are the types of jobs that we'll try and identify and pass along to you. But if there's other things that you want us to do that you think would build value for your membership, reach out, let us know, because we want to make sure that we're helping you. That's the goal here, is to really make sure that we're all fulfilled.
You talk, we listen.
Yeah,
White Coats of the Round Table.
Oh, so sultry.
You got it.
All right, John, until next time.
All right, guys, see ya.
All right, see you guys. Hold on.